This is PediaCast.
Welcome to PediaCast, a pediatric podcast for parents. And now, direct from the campus of Nationwide Children's, here is your host, Dr. Mike.
Hello, everyone, and welcome once again to PediaCast. It is a pediatric podcast for moms and dads. This is Dr. Mike coming to you from Nationwide Children's Hospital. We're in Columbus, Ohio. It's episode 549. We're calling this one Asthma Update. I want to welcome all of you to the program. It is also our very first episode of 2024, and I hope all of you had a fantastic holiday season spent with family and friends. It's going to be time here soon, if not now, to get sort of back into the routine swing of life, which also feels good and provides an opportunity for new things and learning new things, growing as we embark on a new year. And in this particular episode, we are going to talk about an important topic, which really it's one of the most common childhood diseases in the United States and around the world. And so I think it's a terrific topic to kick off the year, and that is asthma. It's a topic we cover, I'd say, every couple years, and it's an important one because asthma impacts really millions of children and teenagers in the United States. It results in millions of emergency department visits, hospitalizations, missed school days, and missed work days. In fact, asthma is thought to cost the economy over $50 billion annually, and that's just here in the United States. But here's the thing, asthma does not have to cause so much disability, hospitalizations, and missed school and work. Acute, what we call exacerbations of asthma. So flare-ups, when you really have, you're cruising along, doing well with your asthma, and then all of a sudden you're wheezing a lot and having difficulty. Those can be prevented, but you have to understand the mechanisms of the disease. In other words, what's happening inside the lungs. Now, when I say prevented, that doesn't necessarily mean that if you have asthma exacerbations, that it's always your fault. They happen. I guess what I should have said is that severe exacerbations can, in a lot of cases, be prevented by acting early and doing the things that your physician asks you to do when you very first start to have symptoms, or when you can predict that you might have symptoms based on, if you have a cold or you've been exposed to a specific allergen or it's a particular time of the year. There are things that you can do to prevent severe flare-ups of asthma. Now, nothing is 100%, and so again, I think it's really important to say out of the gate that if you do experience that, you may have done everything exactly as your physician wanted you to do. Sometimes it just happens, but in many cases, severe flare-ups can be avoided. And once you understand that, the types of management that we use, both daily medicine and medicine intended to treat those flares, once you put all those pieces together and make sense of this common disease, studies show that actually improves outcome. And so it really is important to understand asthma, to have a grasp of why we use maintenance medicine, controller medicine every day, and why we use rescue medicine and those inhalers to really help you when you're having problems. So I think understanding the disease, understanding why we do what we do, really does help in terms of folks managing their disease and improving outcomes, reducing emergency department visits, reducing hospitalizations, reducing time that may have been spent in the pediatric intensive care unit. And so our hope today is really to impart knowledge on the latest evidence concerning asthma and its treatment, which will hopefully empower you to keep asthma under control and out of the hospital. To help us with this sizable task, we have a terrific guest joining us in the studio. Dr. Lisa Ulrich is a pulmonary medicine physician and a member of our asthma treatment program at Nationwide Children's Hospital. Before we get to her, let's cover our usual quick reminders. Don't forget you can find PediaCast wherever podcasts are found. We're in the Apple and Google podcast apps, iHeartRadio, Spotify, SoundCloud, Amazon Music, and most other podcast apps for iOS and Android. If you like what you hear, please remember to subscribe to our show so you don't miss an episode. Also, reviews are helpful wherever you listen to podcasts so that others who come along looking for evidence-based child health and parenting information will know what to expect. We're also on social media, really all the social media platforms. Simply search for PediaCast to find us. And our contact link is over at the landing site for our program, PediaCast.org, if you would like to suggest a future topic for the program. I also want to remind you that the information presented in every episode of PediaCast is for general educational purposes only. We do not diagnose medical conditions or formulate treatment plans for specific individuals. If you have a concern about your child's health, be sure to call your healthcare provider. Also, your use of this audio program is subject to the PediaCast Terms of Use Agreement, which you can find at PediaCast.org. So let's take a quick break. We'll get Dr. Lisa Ulrich connected to the studio, and then we will be back to provide an update on asthma. It's coming up right after this. Dr. Lisa Ulrich is a pulmonary medicine physician at Nationwide Children's Hospital and an assistant professor of pediatrics at The Ohio State University College of Medicine. She has a passion for supporting children, teenagers, and families impacted by asthma. That's what she's here to talk about, an update on asthma. And we're calling this an update because we have certainly covered asthma many times on this program, but there are always new treatments and guidelines coming down the pike. And one of our goals here on the podcast is keeping all of you up to date on the latest and greatest treatment strategies and guidelines as our understanding of childhood diseases grows and expands. Before we get into the nuts and bolts of our discussion, let's give a warm PediaCast welcome to our guest, Dr. Lisa Ulrich. Thank you so much for stopping by today.
Thanks for having me. I'm excited to be here.
Yeah, I really appreciate you taking time out of your busy schedule. So let's just start with some basic definitions so we're sort of all on the same playing field. What exactly do we mean by the terms wheezing and asthma, and are they interchangeable?
So they're actually two very different words, but kind of related together commonly. Wheezing is a really specific sound, and it can be confused for a lot of different sounds. And so it's helpful if you have a child you're worried about wheezing, if you could take a video even to show your physician so that they can sort of interpret, is this really wheezing? What it sounds like, it's almost like a whistling sound that happens when you have trouble moving air in and out of your breathing tubes. And that's because your breathing tubes get a little narrowed, and as air has to move through that, it becomes more noisy. And so wheezing is a specific sound that happens with that. Usually you need a stethoscope to hear it, but sometimes it can be so loud you can actually hear it without even having a stethoscope. And so parents can hear it even without a doctor listening. It most commonly happens when you breathe out, but can actually happen when you breathe in. And so wheezing can look a little different for each kid. And so sometimes it's hard to judge, is this definitely wheezing or not? Asthma is when you can have wheezing, but asthma can happen without wheezing too. Asthma is actually an underlying health condition. It's a chronic lung condition that is caused by irritation or inflammation in your airways that causes that narrowing, which that narrowing is what causes that wheezing for kids. And so kids who have asthma can often wheeze, but you can wheeze without asthma too.
I think that one of the things that physicians get asked a lot in primary care, in the urgent cares, in the emergency department is, does my child have asthma? So, they come in wheezing. What answer should we be providing for families when they ask if their kiddo has asthma?
Yeah, I love when families are even thinking about, is this asthma? If they're hearing wheezing and asking if they're worried, I think that's the most important thing to do. If you have a worry, talk about it with your provider. Asthma is diagnosed a lot of different ways. The most common way that we diagnose asthma in pediatrics is there's no one specific test you have to have done. It's sort of based on the history. And so really those conversations with family make all of the difference. If your child's had wheezing several times in life, so we know that you can wheeze when you get colds. Usually when it happens more than 4 times, though, we really start to think, maybe we should think more about this, and it's not just a virus doing this, that there's something else underlying. The other big thing that we think about is if you are wheezing when you're not sick. And so if you notice when your child is running and playing, or even just kind of sitting and resting, if they're making that wheezing sound or having any breathing troubles outside of playing or being sick, then I think we really want to start thinking about asthma.
And in terms of other conditions that can go along with asthma, since it is sort of an allergic sort of disease that's down in the lungs, when we talk about allergic rhinitis or hay fever, seasonal allergies, all of those words describe the same thing, but that's happening in the upper airway. And it can happen on the skin too. And then we call it eczema, or in doctor land, we may call it atopic dermatitis. But if you see those other things along with wheezing, does that make it a little more likely that it could be asthma?
Yeah. So if you have, we call it an atopic triad, which is a really fancy way of saying you have kind of some of those allergy type symptoms or you have eczema, you may be more likely to have asthma. And it's that same inflammation that's causing that skin irritation and causing that runny nose and that congestion that you might be getting is causing that same irritation in your airways and in your lungs. And so you are more likely to have asthma if you have those things.
So how common is this condition, and who is at risk for developing asthma?
So asthma is actually really common. The Center for Disease Control publishes some statistics on it. 2021 was one of the most recent ones that I saw, so there'll be more coming out soon. But really, back about 2 years ago, 6.5% of kids less than 18 years old in the US actually had asthma. It's more than 25 million kids. And so it's really common that we see this. You're more at risk if you have asthma. If there's actually a variety of things that can put you more at risk. If you have a really strong family history, so a parent with asthma, that can make you more likely to have asthma. If you have some of those other allergic type conditions like the eczema or allergies, and actually sometimes if you have certain bad viral infections early in life. And so there's some evidence that if you get RSV or one of the common bronchiolitis viruses really early, that can potentially make you more likely to have asthma.
Just to interrupt really quickly, because we do talk about science a lot on this program. When you see something like that, that could be, could it be that a child who is going to develop asthma, maybe genetically, is more likely to have a big problem with RSV? So how do we know if the RSV caused the asthma or the asthma caused the RSV to be severe?
Yeah, it's a great question. I don't think we know the answer definitely yet. It's not a guarantee or even a promise that if you get RSV really early in life that you're definitely going to get asthma. There's so many things that go into it. But it's one of the questions that we may ask you about when we're taking a history about your kid's asthma, because it can sort of point us in one direction versus the other. But science hasn't fully proved that absolutely you get this and you're going to get asthma.
Yeah. It seems like asthma is increasing in incidence, at least here in the United States. And certainly as I think about my career, when I was a resident, sure, we saw a lot of kids who had wheezing and asthma. But it just seems like there's a lot more of it these days. Is that just my own biased observation, or are we really seeing an increase in asthma?
It's a great question. I don't have a necessarily fully evidence-based, science-based answer. I do wonder if part of it is just we're better at diagnosing asthma now. Even when I did my residency, 13 years ago or something, there was concern sometimes about diagnosing kids too young with asthma, or maybe you had to reach these specific criteria. I feel like we're more aware now and really want to intervene early for these patients. There's a lot of other things that can impact your asthma too. And so pollution, smoke exposure, we know that those things are not uncommon for our kids. And so that can contribute to potentially some of the increased asthma that we may be diagnosing. But I don't know that there's actually a specific, it's increasing by this much each year.
Yeah. What about the cause of asthma, like down at the cellular level? I think, it always seems to me that if we increase health literacy and if we can help patients and parents and families understand sort of the bodily process that underlines a particular condition, it does help explain why we do the treatments that we do. Mm-hmm. And then I think when parents can understand the process and why we're doing, why we have a particular suggestion for treatment, that then they'll be more on board for carrying out what we're asking. And the same thing with the kids, if they can understand it at their level. So if you could just sort of help us understand exactly what is happening down in those airways when someone does have asthma.
Yeah. So we've learned a lot about asthma in the last many years. Like you mentioned, there's always new things coming out, and we can talk maybe at some point about how we've learned there's different types of asthma. And so different pathways can bring you to have that irritation in your airways. But really, the heart of the issue with asthma, for any reason that you have it, is that you get irritation or inflammation in your airways, even when you're otherwise healthy. And so if you're feeling well, doing well, your child may still have that inflammation in their airways from asthma, and that can be caused by a variety of things. But that is shown in swelling of the airways. So normally your airways are nice round tubes that air flows in and out very easily. With asthma, even when you're healthy, those tubes are a little swollen. And that's because of that inflammation. That makes air a little harder to move through. It can cause that wheezing, can cause your child to breathe a little faster, maybe have to work a little harder to breathe when they're exercising. And so treating that inflammation is really what we want to get to for your child's asthma, to make sure that we can open up those airways to be nice round tubes again so that they can breathe easily.
And I would think that the triggers in a particular child are going to be similar, meaning that if it's tree pollens, for example, that tend to flare up someone's asthma, you're going to see a seasonality to their disease. Whereas if it's something like dust mites in the house, which all of us has, it doesn't mean that you have a dirty house, then you may see it all year long. Or if you're, have allergies to cat dander, then that could set off your asthma. And again, that's something that might be there all year. So I would suppose like how it presents in terms of timing kind of depends on what exactly it is that you're allergic to, correct?
Yeah, that's where history makes such a difference. So the conversation with the family really helps us to decide what type of asthma does your child have? What are their triggers? And really helping to decide, is it possible to avoid those triggers? Like you mentioned, everyone has dust in their homes, and there's a lot of animals for places you visit and things, even if they're not in your own home. And so it's really important to identify those triggers so we can work together to figure out how can we try to prevent that exposure to decrease that inflammation that it's causing in those airways, because each trigger causes more inflammation.
What signs and symptoms then go along with asthma? We've talked about some of them, wheezing, of course, being the primary one. But as you said, as a parent at home, you might not hear your child wheezing, and there's all sorts of other noises they can make when they breathe. So, you may be unsure if it's wheezing or not. What are some of the other things that go along that could kind of give you that rounded picture that, this is asthma that we're dealing with our child?
Yeah, I think it's important definitely to think outside of just wheezing. Coughing is one of the most common things that we see with asthma. So coughing when you're not sick, or even if your child gets a cold and you notice every single time they get sick, that cough is just lasting for weeks and weeks more than other kids, that's sort of a red flag that maybe we want to think about talking to your provider to decide, is there something more than just a cold causing this? Shortness of breath. So if your child feels like it's maybe a little harder to breathe than normal, or you're looking at your child and they're working harder to breathe when they're running compared to the other kids, that could be another potential sign that you should talk with your doctor. And then older kids, we don't expect younger kids to be able to tell us this, but older kids will sometimes tell you that it feels like it's hard to get air into their lungs, or they describe it as a tightness in their chest. And that's actually a common presentation for a lot of patients with asthma, is it just feels like my chest is tight and I can't get those big breaths that I want to be taking.
Yeah, absolutely. If you have wheezing, we've said that especially recurrent wheezing, we start thinking about asthma, and you'd said, about 4 times in the past. Again, it's not a hard and fast rule in terms of the number. It could be the first time, and if there's a really strong family history of asthma, and you treat it like we treat asthma and it goes away, you might be able to diagnose it a little bit earlier. But there are other things that can cause wheezing as well that we ought to be thinking about as physicians and as parents. So what are some other conditions that could be associated with wheezing that may not be asthma?
The most common one that we see as pediatricians is viruses. And so a lot of viral infections or colds can trigger wheezing for patients. And not every time does it mean that they have asthma. There's some other more rare things that can cause it. And so if your child has wheezing that is suddenly present, that wasn't there before and doesn't go away, we think about, did they accidentally swallow something? Did something slip into their airway? Were they chewing on a hard candy, or did they put a Lego in their mouth and start choking? That's something that we always think about, and why we ask sort of exactly when the wheezing started and how long it lasted. Some kids who've had wheezing their whole life, we think about, is there something abnormal about the airway outside of even that swelling? Some kids will have a blood vessel pressing on their airway that can cause that wheezing type sound. And so we get more worried about things that aren't asthma when that wheezing is kind of always present.
And this time of the year, we also think about bronchiolitis, and which is most frequently caused by RSV, or respiratory syncytial virus. But there are other viruses that can cause bronchiolitis as well. You may hear wheezing with that, but as we mentioned, that's not really a good predictor. You may go on to develop asthma, or it may just be a one-off thing. And once the RSV is taken care of, your body's immune system has fought it off, then wheezing's not really going to be an issue anymore. And it's just hard to tell.
Yeah, that's definitely true. Bronchiolitis is so common this time of year.
Yeah. So then how do you settle on the diagnosis of asthma? I mean, you'd mentioned, if it's happening recurrently, but if, a lot of parents want like a test, can you prove to me that my child does have asthma? Because it's a label, and, parents want to make sure that their kids got the right diagnosis. So how do you determine that, yes, this is asthma?
Yeah, it's one of the most common questions we get asked as a pulmonary physician, because so many other conditions, there's a test. We can do this one test and I can get a report that says, yes, you have this condition. Asthma, unfortunately, does not have that. There is breathing tests that your child can do when they're older. Usually it's a hard test to do, and so usually they can't do it until at least age 5 or 6. And so we don't even try doing that until they're that age. That test can be helpful to diagnose asthma, but we really don't need a specific test. It really is that conversation with the family of how many times have you seen symptoms? How often are they occurring? How do they respond when we try different medications? Sometimes your physician or your provider may have to actually try albuterol, which is a common inhaler that we use to treat asthma symptoms, to see if it makes a difference. And if it does, that's really helpful in deciding, could this potentially be asthma? We'll ask a lot of questions about your family history to see if it runs in your family, and then also about some potential things that can trigger asthma at home, like smoking exposure is something that can really impact children. And so we want to make sure that there's not other things that could be causing these symptoms for them. But it really is those conversations. There's no X-ray that can tell me your child has asthma.
So it's a clinical diagnosis, meaning that we're taking the history and the physical, in the clinic, and making a diagnosis based on all of those data points without necessarily a test. And that can be that can actually cause several issues. One, as you said, treating and then seeing what helps can help us sort of confirm that diagnosis. If you have recurrent wheezing and you do the treatment that we're about to talk about and it gets better, and that happens a few times, then you don't really need a test. What it is based on the treatment. The same thing can be said for things like heartburn, and you do an antacid and it gets better, and that does help you figure out what the diagnosis is just based on the history and how you respond to treatment. But the thing I really wanted to point out with this is that then from the parent standpoint, sometimes we'll do something and it does not help. And that is also really important for us to know. So I think from the parent standpoint, they sort of expect doctors to be able to say, this is what it is, this is what we're going to do. And then if what we suggest we're going to do doesn't work, you either think, well, it didn't work, that doctor didn't know what he was talking about. You may feel embarrassed or not want to go back to let the doctor know that didn't help. You may have the attitude, well, I didn't think I was going to help anyway. And all of these things that we see. But it's really important for parents to let doctors know when things don't work, even if it happens 3 or 4 times. We're not going to get frustrated. We need to know what works and what doesn't work so that we can pick a different plan because we're going down a different pathway now. Do you run into this scenario I'm talking about, right?
Yeah, it's very true and very common. Actually, so there is specific evidence-based asthma guidelines that are 300 plus pages long. And one of the most important things in there that you read as a pediatrician is to really treat asthma, you have to partner with the family, and it's a team effort because we can prescribe a lot of variety of treatments, but we need the family because they're the ones seeing their child every day and watching these symptoms to give us continued information back so that we can adjust that treatment or go down a totally different pathway. And so absolutely, families are essential in deciding, is the medications working? Is this truly asthma? That kind of continuous follow-up with your provider is going to make a world of difference. And your opinion makes a huge difference in making sure that your kid gets the best care possible.
Yeah. And I think that's even more important when it is a clinical diagnosis, because when, we can do a test and say, yes, this is what it is. This is the standard treatment. This is, what we're going to do. Although in today's world, with genomic medicine, we may tailor our treatment based on your DNA. Because, then we have a better idea of what works and what doesn't work. We've talked about that on this program several times as well. But it does, when it's a clinical diagnosis, sometimes there is some trial and error before you figure out exactly what's going on. And so patience on the part of parents and families and on the part of the doctor is important. And I love the way that you put that in terms of it being a team effort and a shared decision making and, talking about risks and benefits of the various treatments, and all is really important. Speaking of treatment, and this is where our asthma update comes in. So how do we then treat asthma? And there's really sort of two arms to this. One is sort of chronic long-term treatment to try to keep things under control so you don't have wheezing in the first place. And then there's also then the treatment of an acute, an episode where you do have wheezing and you want to make that wheezing go away. So let's start with the actual wheezing. How do we treat kids that are wheezing? And whether it's asthma or not, it's sort of similar treatment, right?
Yeah. So the most common way that we'll treat wheezing, particularly if we haven't trialed other therapies early on, is we use a medication called albuterol. This is an inhaler or a nebulized medication, which kind of is given to your child as a mist that helps to open up the airways and prevent spasms from happening in your airways. And so can really treat that wheezing pretty quickly if the child is going to respond to it.
Now, the albuterol, so it relaxes the smooth muscle, and then that helps to open up the airway. So it doesn't really get rid of the swelling, but by relaxing those muscles, it helps to open up the airway despite the swelling, correct?
Yeah, that's correct. So it doesn't treat that irritation or that swelling that's narrowing the airways, but when those airways get squeezed by asthma being triggered by certain things like a virus or an allergy, it can treat that. And it treats it temporarily. So it only lasts about 4 hours, typically can last a little longer for some kids, but it's a temporary treatment. And that's where we really want to get down to, where we're treating the overlying inflammation or that swelling so that we can keep your kids' lungs really healthy.
And there is also other bronchodilators, is what we call them, because the bronchioles or the bronchi are those airway tubes. And then we say dilator because we're opening it up or dilating it. So bronchodilator. And there are other ones other than albuterol that could be used, but often those are going to be used like in the hospital setting, correct?
Yeah, so there's different medication that's called Atrovent or ipratropium that we often use when your child's sick enough to need the emergency room. Occasionally we'll use them at home if they're a child that's been followed with pulmonary and we have specific history that we know that we need it. But it opens up those airways or prevents those spasms and relaxes those muscles a little bit differently. So uses a different pathway, and so can be used in combination with that albuterol inhaler to relieve some of that spasms that we're seeing.
Yeah. I also want to talk a little bit about the delivery of the albuterol. And this is an area that has been evolving, I feel like, over the past few years. So traditionally, we have always used, especially if a kid has asthma, so it's not just a one-time thing, it really is recurrent, is to have a nebulizer at home. So a machine that you can hook tubing up to, you put the albuterol in, you have the face mask, and it gives you that mist over a set period of time. And then we also have meter dose inhalers, which is the puff and we can put a spacer on that to help with the delivery. Is there a difference between those two modalities of delivering the albuterol?
This is one of the most common questions I get from families, particularly if they're used to having that nebulizer, that machine that creates a mist. It can take time to give that medication to your child. It can take 10, 15 minutes. It's really hard to get some children to sit still for that, to keep a mask on their face or to keep a mouthpiece in their mouth to deliver all that medication. And so fortunately, there's been really good evidence that says those meter dose inhalers, if they're used with those spacers or that chamber at the end of it to deliver the medication, are just as effective as the nebulizer albuterol. And so when we see your child in clinic or you're seen anywhere and they're talking about these inhalers, it's especially important to really understand how to use those spacers, because we know from all the evidence that you get more of the medication and it's much more effective when we use those spacers with those meter dose inhalers. Makes it much easier to give your child the medication because you can do it on the go. They don't have to sit for 10 or 15 minutes. So it's a really nice option that really is just as effective as the nebulizer albuterol.
And from the parent standpoint, please don't be embarrassed to ask how to use the spacer appropriately. Even if your child has asthma and you've had the spacer at home for a while, when you do see your medical provider, just say, hey, can you explain again the proper way to use this? Because it's not going to be as effective if you're not using it correctly. And just very briefly, because this is hard to do in a audio podcast format, but you're going to have that spacer on there. You're going to give a puff and let that stay in that chamber. And then you're going to have your child take a big, deep breath in so that the air that's in that chamber goes down into the lungs. And you just want to do one puff, breathe it in. And so if you're doing two puffs, for example, you don't do two puffs together, right? You do one, have them breathe it, do another, have them breathe it.
The great thing about the spacers is we really customize how we use it based on your child's age and their development. And so for younger children who aren't able to take a big breath exactly when you say and hold their breath, we actually have spacers that have a mask on the end that you do exactly like you said. You put in the one puff. You don't have to have your child take a big breath though. You can actually have them just breathe normal. And there's a little flap you can watch that you'll watch for 6 to 8 breaths. And once you see your child take 6 to 8 breaths, you know they got their medicine. You wait about a minute, you give another puff. Doing the same thing, waiting about 6 to 8 breaths before you take that mask off. When your child's a little older and can follow directions, there's different spacers that can go right into their mouth, or you can use a mask. Some kids use a mask. So I love that you mentioned talking about it every visit, because your child's preference, your preference may change with these spacers. And it's important that even if you know how to do it perfect, we're making sure your child has the right size spacer. When your child's able to follow directions, we do just like you said. You put the inhaler in, you give it a puff, you have them take a slow, deep breath, and then they hold their breath for about 10 seconds. You wait a minute, and then you give them that second puff. But it's nice that you can customize based on your child's preferences and kind of how old they are, exactly what spacer they need to use. And that's how we know they're going to get the perfect amount of medication.
Yeah, that's great. Traditionally, we have recommended 2 puffs, just sort of to everybody. But it seems like you would get more medicine with a nebulized treatment. Maybe I'm wrong about that. Is 2 puffs the same as a breathing treatment, or should we be using more puffs than that?
This is where it's really good to talk to your provider and where we have been able to customize asthma treatment based on each child's individual needs. Typically, we say 4 puffs, maybe even 6 puffs is closer to that nebulizer treatment dosing. And so if you find that you're doing 2 puffs, which is often what we start with, particularly with young kids, just isn't relieving their symptoms, they're still coughing or they're still wheezing, we may need to give them those 4 puffs to be equivalent. And so talking with your doctor to figure out what should my exact asthma sick plan be is going to be very important, because most of the children that I see who are having a lot of symptoms often do need 4 puffs to totally relieve those symptoms.
Yeah, absolutely. And again, it's not going to be the same. One size does not fit all with asthma. really, it does take some tailoring to the individual patient. And that's also where some trial and error come in, correct?
Yeah, that's where it's really important to give your provider that feedback where if you feel like I tried this and they were sick and it didn't work, we still had to go to the emergency room, or they were still coughing and sick and I didn't feel like they were getting better. Absolutely, we should be tailoring that therapy. And we want to do that, and we can do that.
So we've been focusing on the treatment of wheezing. So when your asthma flares up, that we want to get that wheezing to go away. We want to open up those airways. How do we treat asthma then in terms of sort of everyday treatment to try to prevent that swelling in the first place?
So if your child has asthma, particularly where they're having symptoms between illnesses or they're having really frequent flares of asthma symptoms, we strongly recommend they have what we call an asthma preventative or a maintenance medication. This is targeted specifically at treating that inflammation or that swelling of the airway. And there's actually a whole variety of medications that we can use for this. And there's really good evidence to tell us which one to start at, which level. But the basic principle of all of those medications is to treat that inflammation, we need to use an anti-inflammatory. And so the most common thing that we will start with, or is in most of all of these inhalers, is what's called an inhaled corticosteroid or an inhaled steroid. This is a great anti-inflammatory medication that when giving through a spacer, if you're using a metered dose inhaler like we talked about earlier, goes right to those airways and treats that inflammation, calms that swelling so that your child's airways can be nice and open and not have that swelling present every day. Those inhalers really only work if we take them really consistently. And so we want to work with your provider to figure out exactly what medication and regimen is going to work for your child because they have to be taken every day and they can take a few weeks to take full impact or full effect on that swelling.
When parents, especially when they first start using an inhaled steroid, may be wondering, is it really safe to give my child a steroid every day, especially when they don't have symptoms? Because, if the steroid is working, we're going to prevent wheezing, but then you can start to think, oh, they don't really need this anymore because they're not having wheezing episodes. And I'm concerned that this is a steroid that I'm putting in my child's body every day. Is that a real concern that parents should have?
I love when parents ask these questions because I think most parents have them and often are scared to ask. And it makes such a difference. If you have a worry about your child's treatment, I want to know so we can talk through it. And it's a thing that we think about even as providers, that it is a steroid. It's a lower dose inhaled version of the steroid, and so much less risk of side effects than the liquid or the pill version of steroids that your child may need if they're getting so sick from wheezing that they're needing treatment in the emergency room or extra help from their providers. But typically at the lower doses that we use, we don't commonly see side effects. We do screen for them, and so it's really important to follow up regularly with your doctor. There's a small risk that your growth could be slightly slowed, like 1 centimeter slower than if you weren't on these medications. But there's also great evidence if your asthma is really uncontrolled, that can impact your growth too. And so what we do is work with our families and follow up very frequently to make sure that the patient is on the lowest dose possible to treat that inflammation. And so it's possible that your child's inflammation is so severe to start with, they're having so many symptoms, we may need to start with a little higher dose inhaled steroid. And then we want to see you back quickly so that we can make sure they're doing better. We can lower that dose and really decrease those risks of any potential side effects. But these medications are really widely used and very low risk for side effects for most patients.
This is probably going to be a little less common, but if you have a child who really does have a seasonal pattern, maybe it's every fall and winter, but then spring and summer, they're fine, or it may be, more spring and they're fine in the fall, or only spring and fall, because it could, depending on what you're allergic to. Do you find that in some kids you could just start using the inhaled steroid 2 or 3 weeks before you would predict that they would begin to have a problem, or is that really more in adult patients and you see that less in kids?
Yeah, so it's not something that's necessarily written in our guidelines to do specific periods off, But we know that asthma is moving more towards that personalized medicine or really customizing to the patient and family. And when we see a clear history of we know what your triggers are, we know when your flares happen, it is occasionally true that we do take times off of these medications or lower medications at specific times of the year. And that's where following up and kind of paying attention to those patterns your child may be having with your breathing is really important, because we can and we do want to customize their therapy to exactly the type of asthma they have. And so I think it's a possibility for some children to do that.
Yeah. And then flu vaccines and COVID vaccines, are those, since we have said that a trigger can be viral illnesses for asthma, it would seem you might want to avoid getting the flu and COVID, and since we have and RSV as well. And so since we have vaccines for these things, are those going to be important for kids with asthma to have their seasonal flu and COVID vaccines?
Absolutely. So viruses are the most common trigger for asthma for most kids. And so when we have vaccines that are as effective as these vaccines to help decrease the symptoms of those viruses or even prevent you from getting them, we really strongly recommend them. And it can keep your child much healthier through these tough winter viral season months where it's impossible to avoid some of those triggers despite you doing everything you can. And so those vaccines can make a big difference.
Yeah. And I want to point out, it's really important to realize that when you get a vaccine, like flu vaccine or COVID vaccine, you're tricking your body's immune system into thinking you actually have the flu or you actually have COVID. And that can make you feel pretty icky maybe for a day or two. You can have the body aches, you might have a headache, you can have a fever, because those are all byproducts of our immune system at work, even when we do have an illness and we experience those symptoms. So a lot of times people will say, oh, the shot made me sick. But there's a difference between feeling icky for a day or two and having the flu for a week and wheezing and maybe having to go to the emergency room and then maybe getting pneumonia as a complication of the flu. So those vaccines are really important, even if you feel, not your best for a day or two after receiving them.
Yeah, I very much agree. We hear families have those worries about those vaccines. And I think it's an important conversation to have, that can be a very normal reaction. And I completely recommend that they still go ahead with the vaccine the next year so that they can prevent getting the true infection, which, like you mentioned, is much worse.
Ultimately, we want to help kids not need to go to the emergency department. Because, it's oftentimes you go and you have to wait and it's inconvenient and you're there longer than you want to be. It can also be expensive. There are lots of reasons to keep kids out of the emergency department who have asthma, and of course, then keep them out of the hospital. What can parents do at home to prevent their child needing to go to the ER or to be in the hospital? Now, I do want to say that if don't not go to the emergency room, because I just said we want to keep kids out. If you need to go absolutely 100%. But what can we do at home to maybe prevent that from becoming a need?
Yeah, I think thankfully with asthma, there's a lot of different things that we can do to try to prevent those severe exacerbations or flares of those asthma symptoms that make us go to the emergency room. One of the most important and best things you can do is to do that preventative or that asthma maintenance medication. So keeping those lungs healthy every day so that if your child does get sick, they don't get nearly as sick. The other thing that I always recommend to families is we talked a lot about that albuterol medication that relaxes those smooth muscles and stops those spasms from happening. It's really important to be comfortable using that at home, using it correctly with the spacer, knowing when to start it. I frequently recommend starting it very early in the illness. And so if you notice your child's getting sick and starting to cough, I would start that albuterol right away and do it about every 4 hours. It's really important to talk with your provider about what should my child's asthma plan look like. We talked about personalized medicine, and every child's plan may look a little different. There's really nice written asthma plans called asthma action plans that color code your asthma treatment. And so there's a green zone that explains what medications your child should be taking every day to prevent your asthma from flaring. And then there is a yellow, sometimes an orange, and definitely a red zone that explains what inhalers or what medications do we give our children when their symptoms are flaring? How often do we do it? And so it's a really good visual reminder that I always recommend putting on your fridge, making sure the babysitter has it, grandma's house has it if they're watching your child, so that everyone's aware of what to do when your child starts to have asthma symptoms. I think that's one of the most important things to have at home because we ask a lot of families to treat asthma. You have to know how to use different inhalers. You have to know to use the spacer. And so the more information we can give you in those stressful moments to look at to help guide how you're going to help your child, the more helpful it is. And so I definitely recommend talking with your provider about what should my child's asthma action plan look like. Can I get a physical copy of it so I can share it with everyone that's caring for my child? So I think that's one of the most effective ways to keep them out of the emergency room is having a really good plan of what to do at home.
Yeah, that is really great advice. Sometimes you run out of the medicine and then, the inhaler gets lost, or, maybe you move or you're shuffling between parents' homes and the inhaler gets misplaced. So I would also say it's important to have that on hand, and not say, oh, everything is fine right now, or, they haven't wheezed in months. If they start wheezing again, I'll call the doctor and get an inhaler. You really want one at home if your child has asthma all the time. And so even if they're not having symptoms, if you've lost it or it's gone, or, you've used all of it, it's empty or it's expired, please get more to have on hand, right?
Yeah, I always recommend having that albuterol or that rescue medication at home and even with you at all times, kind of having it with your child at school. We are happy as your providers to fill out paperwork or whatever information the school needs to make sure that your child has their rescue medications there. If you're going out of town on vacation, bring those medications with you so that you can be prepared if those asthma symptoms do flare, that you have all the things you need to treat it.
Yeah. Very, very important. What is the long-term outlook for kids with asthma? Is this something that they're necessarily going to have their entire life? I get asked that by parents a lot. I'm sure you do too. Or is this something that they're going to sort of outgrow?
Yeah, it's a really common question that we get when I'm seeing a patient with asthma. And the answer is a little bit different for each child. There is some potential predictors that maybe you're less likely to outgrow your asthma. But honestly, the most important thing is keeping your asthma really controlled so that we prevent your airways from being too inflamed and too irritated and give them time to heal up so that we give them the potential to outgrow it. Not every child will outgrow it, and it's really hard to tell who definitely will. But what we do know is that by treating asthma early on, we can prevent long-term complications of lung damage from asthma.
Is there a way to prevent asthma from happening in the first place? You may have a brand new baby at home. You think, oh, we're just starting out. There's a family history of asthma. Is there anything I can do to prevent my child from actually having to deal with this condition down the road?
There's no 100% proven way to prevent asthma. A big thing I want every family to know, if your child does have asthma or develop asthma, it's not your fault. That is something that really anyone can develop. But there are some things we can do to potentially decrease the likelihood. And one of the big things is avoiding smoke. So avoiding any smoke exposure, even during pregnancy. But once that baby is born, making sure they're not getting secondhand smoke exposure, meaning someone smoking in the home and the baby inhaling it. Or another way that we see smoke exposure is often it's in the fabric of cars or the car seats if someone's smoking in the car when the child's not there. And then the child goes in the car and is still inhaling those smoke smells from all of those fabrics. And so avoiding secondhand or thirdhand smoke like that can make a difference to potentially decrease those risks.
What are some hot topics in asthma research these days? If we did an asthma update again in a couple of years, will we be talking about anything differently at that point?
Yeah, so there's some really new and exciting things that have happened in asthma over the last several years, and a lot of them kind of tailor around personalized medicine. And so when we have really severe asthma or asthma that's difficult to control, even with the best and the highest level inhalers, there's specific injectable asthma medications that really can target the underlying cause of asthma and treat asthma very differently. And so we have several of those available on the market for kids with truly severe asthma that aren't controlled. And I think there'll probably be even more use of those down the line to really make sure that everyone's asthma has potential to be well controlled. There's also a newer way to treat asthma that isn't necessarily new at this point, but is still kind of gaining popularity here in the US. It's called single maintenance and reliever therapy. So this is a fancy way of saying that you basically only need one inhaler to treat your child's asthma. That inhaler can be the preventative medication, like we talked about with that anti-inflammatory that they're taking every day, but it also has a special albuterol in it that not only lasts for a long time, but can work really quickly. And so this inhaler can be taken instead of regular albuterol as a rescue. And so it's something that you may hear your pediatrician or your provider start to talk to you about more commonly, is that we really are able to customize that treatment to what your child needs. And so certain ages, we can use that single maintenance and reliever therapy. Certain kids are better candidates than others. And so it's something that I think we're going to be seeing a lot more. And we're already starting to use now.
Yeah. Are those safe to use every 4 hours, for 2 or 3 days, let's say, if they're having an exacerbation, since it has both medicines in it? I'm sure you get asked that frequently.
Yeah. So when we use that single inhaler to do both, there's actually been a lot of evidence. It's been used in Europe for years like this, and is just starting to come to the US in the last several years as our guidelines approved it. But it's safe to do it short term with increased dosing. And the max dosing you can use a day depends on your child's age. And so it's part of why it's so important to talk with your provider about the specific plan for your child, because it's going to look different than even maybe your older child's might. But if it's used short term, it has been shown to be safe to decrease the need for ER visits, decrease the need for those oral steroids. And it prevents some of those exacerbations.
And, I'm glad you brought up the oral steroids, because even though you may be using an inhaler with a steroid in it every 4 hours for 2 or 3 days, that probably is still less total body exposure to steroids than if you had to have a burst of oral steroids, over a 5-day period.
Yeah, that's a great point. And that's one of the pieces that they were able to prove in the evidence when they used the therapies this way, is that when they totaled up exactly how much steroids those patients got, whether it was inhaled or through those oral steroids by mouth, the patients who used that single inhaler to treat both ways got less steroids.
Yeah, very
so
interesting.
That's a big benefit.
Yeah. So tell us about the treatment then of asthma at Nationwide Children's Hospital. Our asthma program, like many things at our hospital, is multidisciplinary. We have lots of folks who get involved in the care of kids with asthma. Tell us a little bit about how we do things here at Nationwide Children's.
Yeah, so we're lucky to have such a multidisciplinary team here and to have so many people who truly are experts that can manage your child's asthma. Our primary care doctors do a great job managing asthma, and they have a lot of initiatives that they use to make sure that we're using that evidence-based, truly best top-of-the-line care and medications for your patients. We have respiratory therapists who are really involved in helping individual patients with asthma, but also overseeing asthma education that's provided at our hospital in general. And so even if you're not meeting a respiratory therapist, or you're not meeting an asthma specialist like a pulmonologist or an allergist, they have kind of helped to tailor the care even in those other asthma locations to make sure that everyone is getting the same level of really high quality asthma care.
Yep. And we'll put a link to the asthma program at Nationwide Children's Hospital in the show notes over at PediaCast.org for this episode 549. And if you would like more information or want to get connected with the asthma program at Nationwide Children's, you can get more information at their website. And again, we'll put a link in the show notes. I'm also going to put a link to some previous episodes of PediaCast that really focused on one narrow aspect of asthma, one or another. So just some examples. We have one episode on exercise-induced asthma, another on our school-based asthma therapy programs. We have a program called Asthma Express, And we do have podcast episodes on all of those things. And again, I'll put links to them in the show notes so that folks can find them. And we also have a couple of great blog posts on our 700 Children's blog. One is Asthma Myths, Symptoms, and another is Back to School with Asthma, which even though it's back to school, I guess after Christmas break here and the holiday break, folks will be going back to school who have asthma. So it's a great time to listen to that, to read that blog post as well. So once again, Dr. Lisa Ulrich with the Pulmonary Medicine Program at Nationwide Children's Hospital. Thank you so much for stopping by today.
Yeah, thank you for having me.
We are back with just enough time to say thanks once again to all of you for taking time out of your day and making PediaCast a part of it. Really do appreciate that. Also, thanks to our guest this week, Dr. Lisa Ulrich with Pulmonary Medicine and the Asthma Treatment Program at Nationwide Children's Hospital. Don't forget, you can find us wherever podcasts are found. We're in the Apple and Google podcast apps, iHeartRadio, Spotify, SoundCloud, Amazon Music, and most other podcast apps for iOS and Android. Our landing site is PediaCast.org. You'll find our entire archive of past programs there, along with our show notes, our terms of use agreement, and that handy contact page if you would like to suggest a future topic for the program. Reviews are helpful wherever you get your podcasts. We always appreciate when you share your thoughts about the show. And we love connecting with you on social media. You'll find us on Facebook, Instagram, Threads, LinkedIn. Easy enough to do. Just search for PediaCast. And then don't forget about our sibling podcast, PediaCast CME. It is similar to this program. We turn up the science a couple notches, and we do offer free Category 1 continuing medical education credit for those who listen. And of course, that includes doctors, but also nurse practitioners, physician assistants, nurses, pharmacists, psychologists, social workers, and even dentists. And since Nationwide Children's is jointly accredited by many professional organizations, it's likely we offer the exact credits you need to fulfill your state's continuing medical education requirements. Of course, you want to be sure the content of the episode matches your scope of practice. Shows and details are available at the landing site for that program, PediaCastCME.org. You can also listen wherever podcasts are found. Simply search for PediaCast CME. Thanks again for stopping by, and until next time, this is Dr. Mike saying stay safe, stay healthy, and stay involved with your kids. So long, everybody.
This program is a production of Nationwide Children's. Thanks for listening. We'll see you next time on PediaCast.